I'm going to pass on to Martine, I think. Is that right? Who's going to be chairing the next session of talks for us?
Thank you very much. Yes, so this session is called micromodeling. So we have 4 speakers lined up. So this next speaker will speak for 20 minutes, and then we're going to have a coffee break. If you haven't got your program in front of you, you might want to remember that. And then we'll have 20 minutes for coffee, and then we've got 3 more speakers, and then we'll have our question and answer, which promises on the strength of the talk so far to be extremely interesting. And then we will break for lunch. So it's my pleasure to welcome Gavin Shaddick of the University of Exeter for the next talk. And his talk is called Dynamic Microsimulations for Epidemics, a Prototype Model. Thank you very much.
Thanks, Martine. Can you hear me and see my screen?
I can indeed.
Right, so 2 ticks. Thank you very much for the opportunity to speak today. This is a presentation about some work being done across a number of institutions, Exeter, Leeds, UCL, Cambridge, but also the Alan Turing Institute, and also a very fruitful collaboration with a software tech company called Improbable. The title, as Martine said, Dynamic Microsimulation for Epidemics, a Prototype Model, and a subtitle, Incorporating Time Use and Health Data into a Dynamic Microsimulation Epidemiological Model for COVID-19. And if that works, a brief outline of the talk, which I will do my best and will fit within 15 minutes so that we can have a coffee break. Basically, we at the beginning of the RAMP initiative, under Mark Birkin's kind of leadership, we pulled together people from many different disciplines to build a microsimulation model for COVID-19 based on the premise that the risk of contracting COVID is the interaction between 3 components, hazard, exposure, and vulnerability. And we've got different models for those 3 components, which we brought together in an integration framework, which I'll briefly describe. I'll then talk about the importance of heterogeneity, which is largely difference in vulnerability and exposure across the population. Something about the technical details of the simulation framework, some example scenarios where we've used it, and then, if I get time, which I suspect I won't, some ideas for future development. So the basic premise is that we have individuals that are moving around every day, indoors, outdoors, going to different places, such as supermarkets, to work, to schools, and we simulate those individuals based on a synthetic population from the Spencer project, which is a project run at the Alan Turing Institute, with the idea that there would be a synthetic population of Britain. We then allow those individuals to visit different locations, and I'll probably use supermarkets as my initial example to try to explain this. If lots of people with COVID go to a supermarket, they impart hazard onto that supermarket or any other location. And as other people without COVID go to that same supermarket, they will be exposed to, well, to other people, but essentially those hazards. And then there's a probability that given that exposure, they will develop the disease and become asymptomatic or symptomatic. Hopefully, if they're symptomatic, they will change their behavior. Asymptomatic, obviously, less chance they will do. And then they, in turn, if they're asymptomatic and they carry on their everyday lives, they will carry on visiting supermarkets, schools, and workplaces and impose hazard onto them. So we've got this hazard allocation, exposure allocation, and then that feeds into a kind of traditional SEIR model framework, where we've got probabilities of each person or each synthetic individual contracting the disease, and then we dynamically update this each day. The underlying spatial interaction models that give us where people spend their day, which supermarkets they will go to, again draw on another project at the Turing known as Quant. And this gives us a method for estimating the probabilities that individual people in our synthetic population visit supermarkets, primary, secondary schools each day. There's a cost matrix to compute trip probabilities. Now, supermarkets and schools are actually relatively simple in terms of getting the data on where they are and the kind of what form they take compared with workplaces. There is no definitive list or database of workplaces across the UK. And so we created virtual workplaces for each employment type within each MSOA. Commuting flows between MSOAs are extracted from the UK census, and then individual people or virtual people are allocated to virtual workplaces depending on their employment classification. So in some sense, supermarkets, we had an awful lot of information on supermarkets from previous projects, and schools and secondary schools relatively well, good information, relatively easy to come by. And then we created these virtual workspaces. Now, I very briefly talked about the idea of hazards and exposures. We need to know how different population subgroups are exposed. What do they do each day? Different age groups obviously will spend their time in different places. Much more likely, for example, simple example, that children will spend time in school and adults will spend more time in supermarkets if they're unlucky. We do know the pandemic has disproportionately affected certain groups of people in areas and groups within areas. So it's important to consider demography, kind of a traditional approach of age, gender, ethnicity. All this information is available from the Spencer population, but also health and socioeconomic status and behavioural patterns. And so we had information on activities, on work, education, consumption, leisure, sports, also locations, how much time people spend in their homes and outside their homes and where they might be, and the travel between locations. And we took as our base population this Spencer data set, which gives information on individuals and household level information. We used propensity score matching to link that to the Health Survey of England and the UK Time Use Survey to get a hopefully representative sample of underlying health conditions. And this is very useful when we were building in things like vulnerable populations and how they might be shielding. And we created a database of vulnerability and other health-related information and activities at the MSOA level. And here's some examples of the kind of information we used in our model: average time spent at home, spent at work, key workers, thinking about people who would not be able to shield and maybe might be more susceptible to exposure to the disease, and also underlying health conditions. So if we look at, for example, where we ran our case study in our initial case study in Devon, there's obviously quite a lot of variation even in the county of Devon between where people live who might have underlying health conditions and also where people, their kind of daily patterns of activities. If we focus in Devon, and this will be our initial case study that I'll present in a minute, we can see that there are clear spatial variation in the proportions spent at home, and thus one might expect to be less susceptible to exposure to the disease, proportions spent at work, underlying health conditions with actually very high levels towards the South Devon and in North Devon, which are traditionally kind of retirement, or at least have a large retirement communities, and the portion of key workers. And they go into all this information on hazards, exposure and vulnerability goes into our simulation framework. This feeds into an SEIR model where we have a susceptible population. Each person within that population has a probability of becoming a case based on their exposure, which comes from the hazards. And then they are determined to be a pre-symptomatic or asymptomatic. Our assumption is that if you're asymptomatic, then you will change your behavior. You will not be going to the supermarket, going to school, and potentially infecting other people. That's different, obviously, for asymptomatic people. And if you are symptomatic, there'll be a period of when you're pre-symptomatic, and after that you will change your behaviour. If you have the disease, we are working on the assumption that you'll be removed from the susceptible population. Obviously now, hopefully, the vaccines will kind of a fast track to that box. Otherwise, we have infected individuals that then impart hazards to locations, and then exposed individuals will potentially, based on those hazards, become cases. The removed, actually, the severity of being removed, obviously the most severe being death. The kind of effects of having disease are based on age and previous health conditions, as to the severity. Now, obviously, to do all this in a daily time step on a large population, the population of Devon is approximately 1 million. The population, the whole UK, of course, is much more sizable. Originally, we wrote this in a combination of Python and R. We actually ran R for the kind of probabilistic parts of this within a Python shell that actually ran the allocation of hazards and linked in with the spatial interaction models. We were very, very fortunate and to collaborate with Improbable, who rewrote the whole thing for us in OpenCL that allows it to be run on GPUs. And then we have almost a kind of live real-time computation, and they built this front end where actually what took us, I think, to run an 80-day simulation was taking us days, now runs in, I mean, I'm not exaggerating, it's less than 5 seconds. And I think this is a really good example of how kind of research software engineering can help in actually making something that theoretically was useful into something that actually can be used in real time. I think I've only got about 2 or 3 minutes left, if that. So I'll briefly go through the scenarios. We've done some extensive kind of case studies in Devon, where we compared our outputs, or at least set up our outputs based on, at the time, what was pillar 1 cases, and then we had a lag to try to work out when the actual infections might have happened. Unfortunately, I've not got too much time to elaborate on this. We modeled lockdown when it happened, and we modeled lockdown based on Google mobility data, looking at the difference between where they were, what they spent their time doing before the lockdown versus the actual lockdown. And so we created a virtual lockdown. We ran this through our model, and we maybe contentiously tried to look at what would have happened if the lockdown was implemented a week earlier than it was. We've also done it a week later, and you can see the results here. These from multiple runs. If lockdown had been implemented a week earlier, conditional on obviously the data and the underlying models being sensible, we can see a clear difference in not just the number of cases, but actually how long the extent of those cases was over time. We can break that down because we've got this based on these individual people within the populations by age group, and we do see distinct differences between age groups and also the vulnerable populations and other characteristics. And we can express that in spatial terms as well, and we do see a difference, certainly within Devon, which we know is the case, that there were outbreaks in different areas, and that some areas of Devon actually managed to escape relatively free at the time, at least, of COVID, whereas some areas were much harder hit. So I'll just finish with some actually current developments, I think probably future developments. At the Turing, there are now a team expanding this to all areas of the UK. That's made much easier by our friends at Improbable with their assistance in the coding and implementation. And this allows us to model the effects of local outbreaks and lockdowns and how best to kind of shut down local outbreaks. the impacts of different shielding policies, and I think the big one at the moment is the balance between vaccination and control measures, which is obviously something that's very relevant given well, the Today programme this morning with different ways of dealing with different variants in different areas. And I think that's almost the time, but that's the end of my presentation. Thank you.
Thank you very much, Gavin. We do have a comment from Jason Ward in the Q&A you might like to have a look at. And as we've got 2 minutes left, maybe I will just pass you on to Luca's question, which is very helpfully labelled for Gavin. Do you account for the specific way individuals may move and encounter each other or get in proximity? In other words, has mobility within a specific environment, supermarket, workplace, etc., any role in your predictions, or do you estimate rates of infection or other parameters only on time spent in those environments?
That's a so Luca, I think. Thank you for the question. At the moment, the model is based on the amount of time you spent in the environment, not on different behaviours within those environments. But Mike, Batty, who I think is speaking this afternoon on small spaces, small places. I can't remember what the exact title is. And that's something we'd like to build into the model, because obviously different members of the population, certainly if you have an existing health condition, you probably act differently in a supermarket or a populated area than if you don't. Different age groups we know will act differently. And I think that's something that we can incorporate in the model if we can relatively simply, because we put some other aspects in, but we do need to have the kind of information of what different groups might be expected to do. And I know Mike's work on that is something we'd be keen to implement.
Let me just say, Gavin, this is Mike Batty. Yes, in our extended proposal, which we're beginning to work on, then indeed we are going to look at this problem directly, in the sense that if somebody goes to a supermarket, they may be going to a supermarket in a very small town or even a standalone supermarket, but they may be going to somewhere in a very big place. And the agglomeration effects, so-called, can be built into these models, basically. So I think in an extended version, we would be able to move people to a location and take account of all the other things that they might do. They might, shop in different ways and so on in different places. So that would certainly be the case. We could build that in, and we have some data for that.
Thank you very much. That's a very interesting comment. So now we're actually into coffee break. So we'll see you in 20 minutes. Thank you.
Thank you.